Sorry, Dr. Jasub, I'm wondering if you can reach out to the rest of your colleagues to remind them to please join. Uh,
Yes, I'll do that now.
Thank you. Okay, good evening, everyone. I think we're about ready to start. Excuse me. Um, and let us see if make sure everybody mics work. Hello, Nelly.
Hi, Joseph. How are you? Good evening.
Good evening. How are you?
Fine, fine.
So
You
I'm going
seem
to
to have
leave.
a flu.
I had a flu about a week ago, but it's left me with this like frog in my throat that I cannot
So,
seem to get rid of. So I'm going to actually get some cough medicine with like codeine in it tonight to just knock me out.
sorry for that.
Yeah. So thank you. Okay, Nelly, I'm going to leave it to you. We can start whenever you wish.
Okay. So, good evening once again, everyone. And as we said, yesterday, we are supposed to start with some of the conditions in postmenopausal, postmenopausal bleeding in postmenopausal women.
Mm.
So let me just share that. So,
Do you need help with that, Nelly?
I'm there.
Cool.
Are you able to see my screen?
Yes.
Yeah. So, I just want to do a quick overview of what would cause pelvic bleeding in postmenopausal women, so that when they present, you can just be able to see and check very quickly what it could be, and it's just to help you to be able to make more of a quick judgment. And yesterday, when I asked, I don't know who went and read about what is endometrial atrophy, because it is the most common cause of bleeding in postmenopausal women. That would actually be the first thing. I don't know if there's anyone who tried, maybe quickly, 1 minute, if there's anyone. If not, maybe we can continue. So is there anyone who attempted to read about endometrial atrophy?
I know I did not, and I don't remember from school. That was a long time ago.
Yeah, okay. I don't know if there's anyone else, or we just move forward.
Yeah, I think we just move forward now.
Okay, fine. So endometrial atrophy is actually one of the most common causes of postmenopausal bleeding. And what happens usually is that after menopause, the ovaries usually stop producing estrogen, leading to thinning of the endometrium, and that is actually what is known as atrophy it atrophies, it becomes smaller, and the vaginal epithelium as well becomes very thin. So the endometrium becomes fragile and poorly vascularized and easily irritated. Even minor trauma or spontaneous breakdown of these delicate vessels can cause light or intermittent vaginal bleeding. So it is just so that you know, there are people who usually confuse hyperplasia with endometrial atrophy. Atrophy is when it becomes smaller, and it is actually an action of the hormones that have already gone down after menopause, which is estrogen. So it makes that endometrium very fragile, and that is why you will find most women with postmenopausal bleeding. And when you put your probe, you'll actually see a normal endometrium, very thin, like we said, it's supposed to be 2 to 4 millimeters for women who are postmenopausal, and that would be endometrial atrophy. That would be one of the reasons. So here you can see. So I want to say that the importance of the pelvic ultrasound in postmenopausal women, one is to evaluate abnormal symptoms like bleeding, pain, or masses. It is usually non-invasive, and it is a first-line imaging tool for women who come in. And we had talked about the gross anatomy, but just to do a quick recap is that, of course, that is the serosa, we have the myometrium, we have the endometrium, and then the uterine cavity, and then the cervix and the vaginal canal. So in women within the reproductive age, the endometrium usually is thick, and we talked about it. We said up to 16 millimeters. But in postmenopausal women, it should not be more than 5 millimeters at any point. So, but in most cases, it should actually be thinner. It should be around 2 to 4 millimeters. So sometimes you can do your scan and you still find a thin endometrium, but that patient is bleeding, that you can diagnose and just say that that could be endometrial atrophy. And as we said, of course, the normal appearance, we had talked about the normal appearance of the uterus yesterday. And in postmenopausal women, the uterus is usually very small, it's homogeneous, and it depends if it had some pathology before, like fibroids, and we'll be able to see that. And the ovaries are also usually very small, and you may not even be able to see them. And even the cervix has also atrophied. It has those atrophic changes. It is thin, and even the lining within the cervix is also very thin. And you can see here we have an image of a uterus that is atrophied. It is very small. And still, in postmenopausal women, we can find a uterus that looks like this. Then you will see, you know, those bright echogenic things that are around the periphery next to the subserosa. You can see where these arrows are pointing. That is the anterior myometrium. And even on the posterior myometrium here, you can see these are arcuate arteries that have calcified, because over time, as they age, there is calcification. So still, this would be a normal uterus for postmenopausal women. You cannot start saying that there is some calcification seen. If I saw this in a person who is within the reproductive age, I would start thinking of things like adenomyosis and all that, or focal endometriosis. So endometrial atrophy, we've said, is the most common cause of postmenopausal bleeding, and it is a thin endometrium that is between 4 to 5 millimeters. It's usually homogeneous and echogenic strip. It's actually paper-like. It's very thin. So a very thin endometrial echo is characteristic of atrophic endometrium, and this occurs primarily in postmenopausal or anovulatory women, people who don't undergo ovulation, because after ovulation is when we have that corpus luteum, which is able to produce estrogen. So often the endometrium is so thin, and it is reflective of sound such that it looks like a continuous line. It's very thin. Then an atrophic endometrium measures less than 4 millimeters, but is more commonly 1 to 2 millimeters, as we've said. In postmenopausal women, there can be occasionally be a small amount of fluid in the cavity, outlining that paper-thin endometrium. And I'll be able to show you in an image. And this is actually transudate associated with cervical stenosis and not associated with pathology. Because sometimes when we have fluid in the endometrium, if it was not postmenopausal, we would be thinking about endometritis. But then this is very common And as you can see in that image there, we have there's some free fluid within the endometrium, and for postmenopausal women this is very characteristic. And when you're measuring now the endometrium, when there is this fluid, you don't measure the endometrial thickness including the fluid, so you need to measure that anterior endometrium, you measure the posterior one, and then you add the two so that you have a measurement. Because if it is more than 5 and you've measured including the fluid, then you will actually be misleading. You'll be misleading yourself, because it might show you more than 5 millimeters, which will be a different pathology, which could be hyperplasia. And we know that hyperplasia is a precursor for endometrial cancer. It can transform. So you can see the next thing about postmenopausal women is endometrial hyperplasia, and this is now the opposite of atrophy. This is thickening instead, and it is greater than 5 millimeters in symptomatic women, heterogeneous or cystic appearance, and may mimic malignancy. And you can see this is usually how hyperplasia, most of them that I've seen looks like this. It is thickened and they have cystic changes around it. And of course, this is not, if you find such an endometrium in postmenopausal women, this is about 12 millimeters. Of course, this has to go for biopsy so that they are able to do proper diagnosis if it is actually benign or it is malignant. So then we have, of course, endometrial carcinoma. This is diagnostic. This does not really well, but maybe you can just mention. Usually, for endometrial carcinoma, in most of the cases, we will have what is known as loss of endomyometrial interface. Usually, the way we see the endometrium as a distinct structure and the myometrium, then we lose it and it looks diffuse. And when you put color, it shows increased vascularity. And of course, this also requires endometrial biopsy. So as you can see here, like the previous image here, you could see we have the outline. We can see the correct outline there. We have the outline of the endometrium in this image. But when we get to this image here, we have actually lost the interface. You can see even the measurement. It's, you cannot really clearly define where is the end of it. Yeah, so this is what happens, especially in endometrial carcinoma. Then we also have polyps, because you might put your probe there, the patient is bleeding, and polyps are usually localized focal thickening of the endometrium, and they are isoechoic. They can be isoechoic with a feeding vessel or pedicle, and that is what sometimes is the only feature that can help you to differentiate between a submucosal fibroid and a polyp. And of course, this may also cause postmenopausal bleeding. And as you can see here, we have, this is a normal uterus. We have a thin endometrium there, but you can see here there is an echogenic bright mass in there. And when you put, this is most likely a saline-induced study. Normal saline was introduced through the cervix into the endometrial cavity so that it is able to outline this polyp very well. And as you can see here, this can also be a cause of bleeding. Even in postmenopausal women, they could also have polyps. Then we have fibroids, which we talked about yesterday, and sometimes they may persist even after menopause, yet we expect them to either calcify or to degenerate, but sometimes they can persist, and it can also be a cause of postmenopausal bleeding. And of course, we talked about them, that they appear different. They can be hypoechoic, hyper, they can be heterogeneous, but they are usually well-defined masses, and they can actually undergo degeneration or calcification. And sometimes even when it's undergoing degeneration, then you can also find bleeding. So as you can see here in this image, we have an image of the endometrium, of the fibroid here, and we even have another fibroid here. So it is still what we talked about yesterday. In this case here, we have a calcified fibroid. Remember, it has been probably here for many years, and what the body does is that it actually, the rim, the edges calcify, and sometimes you may not see the entire rim because of the interface. It is very bright. It has a lot of calcium deposits there, and what it does is that the only thing you might see is a shadow behind it. So you see something like just a small arc here. But this one, like for example, this one had not fully calcified like this one. And that's why we can see the calcified peripheral edges of this fibroid. But here it is the same. It is completely calcified. You've put your probe there and there is posterior shadowing. Then you know that this is a highly reflective interface in a calcified fibroid. And this is also very common in post-menopausal women. You will be able to see. And also, we can also have ovarian cysts. And in most cases, when you find cysts in postmenopausal women, it's not usually a very good sign. In my own practice, that is what I have seen, because in most cases, they could actually end up to be ovarian carcinomas. So you need to check if there is any ovarian cyst, then they can be benign, even in menopause. They can be thin-walled, but in most cases, if you also find a complex cyst or a solid cyst, or any solid mass in the ovary, especially solid masses in the ovary, they are also not very good signs, and they could also cause bleeding. So for cyst evaluation, we had talked about this yesterday, but we can, recap, and we said that a simple cyst there, we can be able to see that uh, it can be non-ovarian or ovarian. It can be inside the ovary or non-ovarian. Then, of course, when we talk about pattern recognition, we want to say, is it a simple cyst? Is it hemorrhagic, which we talked about? And we said that hemorrhagic cysts, they usually disappear 6 to 8 weeks. Endometriomas usually are chocolate cysts, and they are associated with endometriosis, and they persist even after 8 weeks. You will still find it there. Sometimes we also have in the ovary what is known as mature cystic teratomas, and this one will really cast a very huge shadow behind it. And then we also have any other cyst that could be possibly malignant. And as you can see here, it already has just a minute. You can see there is already angiogenesis, and it could point to malignancy. Then, of course, that is just an image of the cyst. Yesterday, we had seen the different cysts. We had the septated cyst. We had the ones with low-level echoes, internal echoes. So ovarian malignancy, usually you'd find like enlarged ovaries. When you measure, it is more than 12 cc's. And remember, in postmenopause, we are not even supposed to be seeing the ovaries. So the fact that you're able to see ovaries and they are enlarged, it is not a very good thing. Then sometimes they could have thick septations, papillary projection, and they could be associated ascites and all that. And that could easily point towards ovarian malignancy. But of course, you cannot diagnose malignancy on ultrasound. It is just a pointer to be able to tell you that this patient needs to go for further imaging. So as you can see there, we have the different types of some of the ovarian cysts that you could find. You can find one that is septated like this, and of course it's not a good thing. We could also have one with a mural node. It is a cyst, but it has a mural node internally. That's not also very good. We also have flank solid components internally. We also have papillary projections. You can see those projections within that cyst. All these cystic structures here in postmenopause, especially in the ovary, is not a very good indicator. So I don't want to go into that, but we could also have adnexal masses, but in postmenopausal women, adnexal masses could either cause bleeding or not, and they can be solid, but this would require you to get a proper scan from the radiology department. So that was just an overview of what I wanted to talk about in terms of.
So Nelly, I have one question,
Yes.
and I've encountered this in when I was practicing. I've had a woman that comes in for postmenopausal bleeding, and then my sonographer is doing the exam, and she does the full bladder, she does the transvaginal, and then she has an endometrium that looks a little thickened. But it's we know that's abnormal. You showed a picture there of a polyp. can you diagnose a polyp without the saline histogram? Because I've done this where I've done the saline histogram and it opens up into a polyp, and I never even knew she had an active polyp within her endometrium. I just thought it was an extra thickened endometrium. Is there any way to diagnose that with just a regular ultrasound, or do you have to do a saline histogram for that?
Yeah, in most cases, especially in postmenopausal women where everything is already too small and all that, it may not be very easy to see a
Mm,
polyp. And that's why if you're suspecting that this patient, you've checked other things and you don't see anything why they are bleeding, and that endometrium it's neither very thin, the paper thin we were talking about, which is
mm,
endometrial atrophy, then you need to send now that patient to the radiology department where they may be able to do a saline induced ultrasound so that they
mm.
rule out is there a polyp or not.
Okay,
But then,
I
of
see.
course, the thickness of the endometrium might be more than 5 millimeters. But you're
Mm,
not able to make out like is it a thickened endometrium or is there something and actually it might even be focal at some point is where it is very thick, the other
mm.
areas look thinner.
I see. I
Yeah.
see. Okay, thank you.
Yeah. So I think with that, maybe we can now go to today's work. I just wanted to do a recap because still you might find your patients who are postmenopausal and they present in the department. So the first thing is, you need to tell yourself, could this be endometrial atrophy? Is it hypertrophy? Is it an adrexal mass? Is it fibroids that are degenerating? Yeah, those are the things that should click in your mind as you're doing your exam. So let's move on to vascular. And
And
in
let me pause just to make sure there are no questions for the postmenopausal, because I almost guarantee that a lot of your patients, you will get a lot of these patients to scan that are postmenopausal. They came into the GP for some reason, whether it's pain, bleeding, whatever. So any questions about scanning a postmenopausal GYN, gynae?
maybe one thing that I forgot to say is that they have to have a full bladder.
Yeah.
Yeah.
Yeah, yeah, definitely.
Mm.
Definitely. And I found that some postmenopausal women, it's very hard to do a transvaginal on some of them because of vaginal atrophy too.
Mm.
Okay. All right,
So
we
if
can move
there's
on.
no question, we can continue.
Go right ahead,
Okay.
Nathan.
Okay. So in vascular, of course, we are talking about blood vessels. And for me, what would easily come to my mind when I'm thinking about point of care ultrasound in vascular, I would only be thinking about a DVT because remember we said POCUS is supposed to help us to make very quick decisions and manage that patient accordingly so that we minimize the adverse effects of delayed care. So
Right.
one of the things that I would think about that would come into my mind when I just think about vascular and I'm talking about blood vessels. One would be a DVT. Another thing would be an aneurysm. Remember, we talked about that in when we were doing abdominal, but still, that would be the aorta. There could be an aneurysm, and also when you're also checking placement of, like central lines, like when there is a peripheral, inserted central line that has through the arms, the upper limb. Sometimes you also want to check that before as a baseline for dialysis before they can do you can actually do dialysis. Sometimes these patients who go for frequent dialysis have they come with a swollen limb and they're telling you they're feeling pain and they're supposed to go in now for dialysis. Then
Mm,
sometimes you need to just put your probe there and see could there be a clot that is there. So those are some of the things that would spontaneously come to my mind in case I'm thinking about vascular. But then let's move on and see what are some of those other things that we could we could actually be able to do in vascular. And Of course, we said in most cases we'd be talking about the lower limb and the upper limb. Remember that most DVTs actually occur in the lower limb. So one of our objectives that we'll be doing is to review the lower and the upper limb venous anatomy relevant to DVT. Then we'll also understand the proper positioning and the compression technique. And then we have to recognize sonographic features of normal veins versus when there is DVT. We'll also learn about what is known as a 2-point versus a 3-point compression exam, and where to apply and how to use the Wells score in DVT risk assessment. Because before you even decide to do your point of care, vascular study, you need to have scored it first using the Wells score risk assessment for you to say that, yeah, this patient, I can actually have, I can do that vascular POCUS. So we have the lower limb venous anatomy. Where we usually start from is at the common femoral vein and its junction, where there is a junction between the common femoral vein and where it forms the great saphenous vein. Then we have the femoral vein itself, which can be, that is the superficial femoral vein. We have proximal, mid, and distal. Then we have the popliteal, which is behind the knee. And then, of course, we have the saphenofemoral and the saphenopopliteal junctions. So that is where most of the time we find DVT. And just to do a quick recap on the anatomy, as you can see here, we have, I'm assuming this is the trunk, and this is the right leg here, and we have the left leg here. So how do the blood vessels usually flow? Of course, we have the IVC, which will branch off into the external iliac vein. It doesn't, well, for the IVC, of course, the blood would be moving from below, coming from down, moving up. But then where we start checking, in most cases, we usually would start with the external iliac veins as sonographers. But if you are not able to locate that, then of course we start with the common femoral vein, which is exactly at the junction. And you place your probe there, you'll be able to see the common femoral vein. As you continue scanning lower, you'll find a junction which there is like a branch off, and that branch off is usually the great saphenous vein. Then we have, which will run superficially. Remember, the common femoral is a deep vein. The great saphenous is superficial. Then the common femoral will actually change as it continues going down. It changes its name. At the femur level, we have the proximal part, we have the mid, and we have the distal just before the knee, and that is called the superficial femoral vein. It is called superficial femoral vein, but in essence, it is not a superficial vein. It is a deep vein. It is a continuation of the common femoral vein. Then at the point of the knee, where you can see that line there, we have the popliteal. And at the popliteal, just as the common femoral vein was splitting, then the popliteal will also have its superficial branch, which is called the short saphenous or the small saphenous. It will also branch off. And anywhere where there is that branching off, that is places where they are prone DVT. And as you can see here, we have another image just trying to help you to understand. We have the external iliac, then it changes at the crease there, it becomes the common femoral. Just before it branches off into the great saphenous, it continues, it becomes the femoral vein, it becomes the popliteal at the knee, and as it continues below the knee, then of course we have the posterior tibial vein, we have the anterior, we have the fibula, we have the tibial, and all that will come and converge at the popliteal, and then it continues. So moving forward, we want to first understand what is known as a Wells score. So I'm starting first with the lower limb because that is where most DVTs occur as opposed to the upper limb. So Wells score, number one, is these are the parameters that you will be asking yourself. You need to have this because it is a clinical prediction rule. before you even do your vascular POCUS, you'll have done this prediction, clinical prediction. You'll have used this well score for DVT. So the first thing is, if that patient has active cancer, remember the disease progression in cancer, one of the complications is that there is usually formation of DVT in most patients with cancer. So the first thing would be, with any patient with an active cancer, that would be a +1. So you write +1. Then you continue. If this patient has paralysis, or they have had recent immobilization, maybe they had a fracture and they have to be sitting for long and all that, that is also another score. That would be another +1. Then recently bedridden for more than 3 days, or surgery within 4 weeks, that is also another +1. So localized tenderness along the deep venous system, if they can point and tell you that I'm feeling there's a pain in a particular point, and when you try and even, palpate, you can feel that it is actually a deep vein, then that is also +1. Another thing is, if the entire leg is swollen, that's another +1. If there is calf swelling more than 3 centimeters compared with the asymptomatic leg, if you compare, let's say, even if you were to put a tape measure and you measure that circumference and find that the other one is greater than 3 centimeters compared to the other one at the calf, then that would be another +1. Because remember, at the calf, beyond the popliteal, we also have the gastrocnemius, which is a deep vessel in the calf itself, and it could also have thrombus. Then another thing is pitting edema confined to symptomatic leg, that leg that has the patient has presented with that pain or swelling or that, and there is pitting edema. When you press and the skin doesn't bounce back quickly, that is pitting edema. That is another +1. When you can be able to see collateral superficial veins, that is varicosities. If you see some varicose veins, that is also another +1. Then alternative diagnosis, at least as likely as DVT. If you're thinking that this could be, it may be DVT because it has not followed maybe most of these criteria, then that will be -2. Whatever you had found, and then you think that it could be an alternative diagnosis, at least as likely as a DVT, then you put a -2. When you add all that, now we go to the scoring. Why were we adding all these things? When it is more or equals to 3, there is a high chance. And that will also prompt you now to put your probe and actually check that there could be DVT or not. 1 to 2 would be moderate. If you find a score of 0, then that would be low chances of DVT. So anytime you have moderate and high score using the Wells score for DVT, then it would prompt you to actually do vascular POCUS. And if you're not able to really make, if, for example, your findings are actually, you're not very sure about it, your findings are equivocal, then what you do is that you send that patient for a comprehensive scan. So what do we use when we are doing POCUS for the lower limb? One is that we use a linear probe, which is the preferred, and in most cases we use a 5 to 12, depending on the body habitus of the patient, because sometimes we have patients whose legs are, the vessels are very deep, or they have a lot of the adipose layer, the subcutaneous tissue is too deep, or they are too big. Then you might actually need to reduce the frequency, even if you're using the linear probe, for you to be able to get that penetration. So the patient usually would lie supine. There is slight external rotation of the hip, and that is what is known as abduction. Then you start at the groin region. That is the common femoral vein. That is where you see in short axis view. And you do what is known as graded compression every 2 centimeters. You follow it and you compress. Follow down, compress. Continue following as you compress. Because that graded compression, remember, a vessel that does not have DVT is patent. If there is DVT, it will not compress. So you continue moving distally up to the popliteal as you continue pressing. You can also use color, and you can also use what is known as spectral Doppler if compression is equivocal, if you're not very sure, is it really compressing completely or not. And remember also, when you put a probe and you see a thrombus, you stop actually those compressions, because it means that you're pushing, you're applying more pressure, and it's like you're applying force to it so that it continues moving. So once, if you identify it, just stop at that, because we said that POCUS usually answers binary question. Is it a yes or a no? Is there a DVT or no? And for the vessels, it is more of compression. The most accurate thing would be compression. All veins would compress, the artery does not compress.
Nelly, can I ask a question? Can I ask a
Yes.
quick question?
Yeah.
Have you run into a point where we use the the linear probe usually for DVT examination, for deep vein examination? I use it both on the arms and the legs. But have you ever run into a situation where the patient is obese and you can't see, that you have to drop the frequency, but you have to go to a curved simply because the frequency doesn't drop enough in the linear?
Yeah, you can actually use now the curvilinear, but you try and make sure that you have your frequency as high as possible,
Mm, okay.
so
As
that you're
high
able
as
to see your,
possible.
yes, like the
Okay.
last, if it is a range of 2 to 5, so put it at 5. Let it
I
not be at
see.
2.
I see. Okay.
Yeah. And the other thing about now the curvilinear probe is that if you have to do, well, this is POCUS, but if it was me as a sonographer, if I have to do the pulse wave Dopplers, for the curvilinear probe, it is actually very hard to
The
achieve the
angle. Yeah.
angulations, yes, the
Yeah.
angle, because of how it interacts with the vessels, because it should be parallel to it.
Yeah. Yeah.
Yeah, but then that would be, too detailed for that. But yes, you can use a curvilinear probe, but you need to make sure that you increase your frequency at least to the highest level, and optimize your image.
Mm,
Like use, the focus properly, make sure that your depth is okay, your gains and all that, so that you're actually trying to perfect an image using the wrong
mm,
probe.
mm.
Yeah,
Okay.
yeah. So we have what is known as a 2-point and the 3-point compression exam. And that is what I was trying to explain, that for the 2-point exam, you only compress at the common femoral and the popliteal vein. If you have to use a 3-point, which is at least more sensitive, then you have to do the common femoral vein. You do the femoral vein at the mid thigh, and that would be the mid portion of that, because usually the superficial femoral has proximal, mid, and the distal, which is closer to the knee. But you actually do that compression at the mid. So you just put your probe medially and at the femur, like
Mm,
mid thigh. Yes. And then we have the popliteal vein, which is behind the knee. So the 3-point is more sensitive, but the 2-point, of course, is faster, and it is common in emergency department. What most people usually have seen them doing is that, but if you can, I would encourage that you use the 3-point compression exam.
okay.
So then we move on. So compression ultrasound, what is normal and what is abnormal? So normal veins would compress fully with probe pressure. You actually apply that pressure, and that is what I said, it is graded pressure. You press it, and sometimes if somebody has a lot of, the patient is big, then it means the compression you'd put more energy, because then the vessel is deeper. So for DVT, there is non-compressible vein, and intraluminal echogenic thrombus may be visible, but sometimes it can also be hypo, especially if it is acute. It could be hypo, but that hypoechoic, but that vessel will not compress. And if it compresses, it doesn't compress fully. If it is echogenic thrombus, when you see an echogenic thrombus there that is very bright, it means it has been there for quite a while.
Mm,
So compression is the most reliable immediate sign, and the artery would remain round and pulsatile, and you have to compare both sides if you're uncertain at the same level. Just put your probe on this leg, see if it doesn't compress or you're not sure if it's compressing or not, try the other one as well. If it compresses very easily and this one was not compressing, then you'd be able to say for sure this one could be having DVT. So for normal compression, as you can see there, we have this image. Oops. We have this image here. This is the artery and this is the vein. When it is completely open, it will be as big as where that echogenic line is. When you compress, it actually almost closes completely, and even sometimes it completely closes. But when you see this one, you can see here, when you press and you compress, it doesn't compress. It remains almost the way it was. We are looking at this gray area here. This one is almost closing completely. But this one here is completely open. And this echogenic stuff here we are seeing is probably a clot according to this image. So it doesn't compress at all. And that is a transverse approach. You've put your image on transverse. It is not longitudinal. So as you can see here, the image we have here, which is this first image, the A and B ultrasound images of normal femoral vein without and with compression. So you see that this one A, there is compression here. We can see here we have an artery here and the vein here. And once we compress, you can see the vein collapses here completely, while we have the artery is still open there. Now, the artery is anterior to the vein in this case, and that is what we've said. After compression, the vein is completely collapsed, indicating normal compressibility. So the image C and D here are ultrasound images of acute femoral thrombus without compression. This is the image here, and we have our vein here. Remember, this is our artery here. We have our vein here. As you can see here, this was without compression. And D is with compression here. It doesn't change. It appears open, you see? And after 1 week follow-up, you can see this is even echogenic. Here you see it was a bit hypo. At this point here, it was appearing like it is more hypo. At this point here, this thrombus is already echogenic. This means it has been there for quite a while. So the patient was followed for acute calf DVT that was not treated. You see, not treated because the image that showed that the patient was not treated, I did not show in this image here, but the outcome is what I have explained here. Because the acute DVT in C is a bit heterogeneous and it expands to the vein. After compression D, the vein does not collapse, but has an oval shape indicating an acute DVT based on the non-compressible but deformable vein. DVT indicates deep venous thrombosis. At this point here, we can see that it is already echogenic, and I said that is an image that I acquired from a patient who presented after was not treated. After 1 week, came back again. So this was the first image on the first day, and then after again this patient was not treated, came back after 1 week, and this is how the image was looking like. So then we have the Doppler findings, because one of the assessment tools that we use in vascular is actually color Doppler, which will give you the mapping. And of course, we said we are using compression, we use color, and we can also use the waveforms, how they will appear. But the most important that we use in POCUS is most of the time we would use compression and color Doppler. Hardly do I want you to interpret the waveforms, because they can mean so many things. It could even be aliasing, it could be picking waveforms from an adjacent vessel and all that. So that is more technical. So here we can see the one thing that maybe I want to explain is the color mapping. When you put color Doppler on a vessel, I know people ask what is the red and what is the blue. So there's something that I usually use, which you can adopt, which is known as BART. That is BART. BA means anytime you see blue, it means that blood is flowing away from the probe. At the point where you are, that vessel is moving away. The blood is moving direction away from the probe at the point where you have placed your probe. Because the same vessel, at some point, if you put it much lower, maybe let's say the femoral vein, for example, you put it at the mid, and it depends on your angulation, it could be blood coming towards it, or it could be moving away from it. So usually the color mapping does not really say that this vessel will always be red or this vessel will always be blue. No, it just means when you see blue, it means that blood is flowing away from where your probe is. If it is red, it means the blood is flowing towards the probe. So that is the interpretation of the color mapping that we see on ultrasound. So as you can see here, we have a normal popliteal vein, and in this image here, the second image, we can see it is the popliteal vein here is compressible once the compression was applied. But in this case here, look at this vein here, and it has that echogenic, structure. It is thickened. It looks bigger than the normal size, and of course this is a thrombus. And thrombuses can either be complete occlusion, it can be partial. If it would be made, let's say up here, and when we put color, we can see part of it halfway, but at the top here where there is the thrombus, you don't see color. That would be partial. But in this image, this particular image here that we have, remember this is color Doppler that has been sampled. Somehow we would expect to see some blood flow flowing here, but we can see there is no blood flow completely, and there is that echogenic structure there. So this suggests that there is complete occlusion because there is no Doppler signal. So additional findings is in Doppler, the veins loss, the veins usually respond to breathing. Like when you breathe, for example, the vein usually has that respiratory physicity, and it affects the veins because of just breathing. But when there is a thrombus, there is loss of respiratory physicity, when you will see on the waveform. But just to mention, not really that I expect you to be doing it, but if you can try. So there is no flow on augmentation, and augmentation usually is, if you've seen sonographers performing ultrasound and they tell you to augment for them, they just want to see when they apply pressure, if that waveform shoots, or if it doesn't, then it means there's a blockage distally, like after the probe where you're compressing. After it, there must be some blockage, because essentially we expect to see the peak of that waveform shooting because of compression. So continuous flow may indicate obstruction proximally, and you use color Doppler if compression is equivocal. So we've talked about that. You can see here, this is a common femoral vein, and of course veins usually have this type of waveform. But you can also see this vein here, we have that respiratory physicity. This is what we were talking about. You can see when somebody breathes in, breathes out, you see this is inspiration, expiration. That is how the waveform would look in the veins. But when there is a continuous flow and there is loss of this, then it could actually suggest that there is a thrombus proximally. So then we have the images there. It is just a repetition. So then we move to the upper limb venous anatomy, because we've talked about the anatomy of the for you, it's the same thing. Like compressing is just compression. at whatever level. The only thing you need to understand is the anatomy, like where are you coming from? From the common femoral, we go to the superficial femoral, we go to the popliteal, and then we check those branches. Where it branches off, the popliteal branches off, that would be the sapheno popliteal junction. Where it branches off at the great saphenous up there, then that would be the sapheno femoral junction, because that is the junction between the common femoral vein and the great saphenous. So then we have the upper limb. And of course, the first thing is usually just to understand your anatomy and some of the key things that we check in the upper limb. The first thing that we have to start with is the internal jugular. Because remember, most of the thrombuses, sometimes when they develop in the hand, it can actually move up all the way to the internal jugular. So we'll be checking, you just put your probe along the neck. When you see the carotid, which is pulsatile there, whatever you're seeing there adjacent to it, that when you compress is internal jugular vein. Then we have the subclavian, which is usually above the clavicle. And this one, you cannot assess it actually like easily, because you really need to angulate your probe to be able to see it. Then we have the axillary, which is in the armpit. And then, of course, we have the brachial artery, which runs all the way down, and you'll be able to see that. Then, of course, the probe that we use, we say it is a high-frequency probe, preferably linear, but anytime that you cannot be able to see any vessel that is deep, you can switch to curvilinear. And we said you make sure that you increase that frequency higher so that you're able to utilize that probe well. So subclavian is under the clavicle and is not compressible because it is on top of a bone. And so you rely only on color Doppler. So this is the anatomy of the upper limb. And as you can see there, the neck, we have the internal jugular, and then we have the subclavian here running along the clavicle. Then immediately after, it becomes the axillary artery at the armpit as it goes down and becomes the brachial artery. And that brachial artery runs all the way down up to the junction. And once at the cubital fossa of the elbow, then the one that follows to the small finger would be the ulnar. And then we have the one that follows to the thumb would be the radial. So that is how you just remember. And of course, the hand has so many peripherals now. And the peripherals, as we have the cephalic, which would of course run on the upper side of the arm, like here you can see the veins, the upper, the peripheral veins that would be running, following that path. Then we would have the cephalic, and you can see here the upper arm cephalic vein. The ones that run medially in the hand, then those, all of them are basilic. From the top to the bottom, they are basilic. From the top to the bottom of the hand, which are superficial, those are cephalic. The one that runs in the middle, from the top up to the cubital fossa, is the brachial. And then the one at that point, it splits now into two. The one that goes towards the small finger is the ulnar. The one that goes towards the thumb is the radial. So that is just a simple way of understanding. And of course, we usually have that median cubital vein, which usually connects the two, that is the cephalic and the basilic. And remember, these are some of the things that now for us sonographers, when we're doing mapping for renal, for fistula placement for dialysis, this is a very comprehensive scan that we do, because we measure the diameters. We want to see the flow, which one is the most patent, and all that, which one does not have tributaries, because they are potential sites for DVT. So for you, if for example there's a fistula, what you will see, like this image here that we had, an image of DVT here, this is exactly what you will see around that fistula. And of course, that is something that would tell you you cannot use that fistula for dialysis on that particular day, you send this patient to go to the radiology department for a comprehensive scan, because what us we want to see is that, is there even the thrill in that fistula? How big is it? The thrombus? How many veins does it involve? How extensive is it, and all that. So for you, if you see something like this and you wanted to do dialysis and the patient has a swollen arm, you can put your probe exactly at the top of where that they can see the swelling. And if you see something like this, then that should tell you that probably that fistula is thrombosed, and you send to the radiology department for proper analysis. They will give you a comprehensive report so that you don't use that fistula. So additional, after that, of course, for the upper limb, it is not very common unless there has been injuries like trauma, maybe there was a fracture, or even cannulation. And of course, now when we are doing interventions like placement of the central line and all that, those are some of the things that can actually cause upper limb DVT, but it is not very common like the lower limb DVT. So 10% of all DVT cases would rise from central venous access associated with central venous catheters, pacemakers, or malignancy. Remember, we said for malignancy, it is part of the disease process, formation of thrombus. So it can be anywhere, maybe in the feet, in the hands, and all that. But we also have thrombosis in athletes, and that is usually in the axillary subclavian axis, especially for athletes who do, a lot of throwing and all that. You can actually find DVT there because of either there is even hypertrophy of muscles around there that are compressing on the vessel itself, and therefore it is causing stasis, and at the end of the day, it ends up causing DVT. So sonographic findings is the same. We talked about compressibility. That is just how we assess in POCUS. It is mostly compressibility. What you need to understand more is the anatomy, how that vein changes course as it goes down. So non-compressible veins with interluminal echogenic thrombus is, of course, suggestive of upper limb DVT. Then we have absent flow on Doppler or loss of physicity. We talked about all the veins would have that physicity phase. Then, of course, the rule of thumb is that you always have to compare with the contralateral one, especially if you're not very sure. And you can also consider catheter-related causes. If there is any catheter that has been placed and all that, you can actually, it is one of the factors. So loss of physicity or absent augmentation with distal compression is still, a finding in Doppler, and it is the same thing even in the lower limb. Color Doppler, that is absence of flow. And chronic versus acute is the echogenicity, and the vessel appearance will differ, of course. And is the well score relevant for upper limb DVT? The truth is, for me, I think yes, but there is no there is really no protocol that has been developed for that well score, but you can always come up with it and just, relate the other factors. Like, for example, we had talked about active cancer, that's a +1 and all that. So the Wells DVT score was originally designed and validated for lower limb Doppler because over 90% of all DVTs occur in the lower extremity. For upper limb DVT, in the subclavian, the axillary, the brachial, there isn't a widely validated well score type of score that is available. However, the same risk factors like immobilization, malignancy, central venous catheter, pacemakers, and all that still apply. So some clinicians have actually adapted the well score to upper limb cases, but evidence is limited and the diagnostic accuracy is less reliable than in the leg, which of course it was specifically developed for. So in practice, for suspected upper limb DVT, the gold standard pathway is careful history and examination. Things like swelling, pain, dilated superficial veins, discoloration, and compression ultrasound with Doppler as first line imaging. We talked about compression. That is what you will be doing. And of course, you can also send them to the lab for the dimers, and this can help, especially in low risk patients. So the well score was officially validated only for the lower limb, but upper limb, no specific validated well score has been developed, but assessment follows the same clinical principles. Plus, the imaging, it is the same. So what are some of the symptoms and signs that they could be? An upper limb DVT is swelling of the arm, which is the hand, especially unilateral. There could be pain or heaviness in the arm. Dilated superficial veins, those are collateral over the chest or the shoulder. Then there is cyanosis or discoloration of the limb. Tenderness along the venous tract, and a decrease in range of motion due to pain or swelling. Those are some of the signs and symptoms. So the risk factors is one, of course, we talked about catheter related. Those are central lines, the peripheral lines, dialysis catheters, pacemakers, defibrillator leads, and of course, effort related, that is strenuous, repetitive upper limb activity in athletes, as we said that. Then there is also malignancy with indwelling lines. There is thrombophilia, which could be, inherited or acquired. You could also have hormonal factors, and pregnancy and even postpartum is also some of the risk factors. Then we have when we were doing the obstetric during my learning, we were actually told that progesterone is one of the factors that can actually cause uh, DVT. And remember that progesterone is what sustains pregnancy. So that is
Yeah.
why it is hormonal. Yeah, I think, is that true, Joseph, right?
Yeah, it is actually true. We had actually, before I left practice, when I retired in my hospital in DC, we'd instituted, just simply because we had so many women that were coming in and out, with DVTs, lower extremity DVTs, that either were in their pregnancy or just after their pregnancies. Usually we saw them just after pregnancy because they'd come back with swelling and pain and things like that. And we even end up losing a patient because of that. So we instituted a protocol that said that, during pregnancy and after pregnancy, we'd always give them a quick DVT scan, especially the ones that had the heightened, risk, because now you're pregnant, which is a risk. Then you're on certain medications because of pregnancy, which is a risk. Then you are, overweight, diabetes, all of this are going to add to the risk. So before that lady left the hospital, we'd give a quick, and we wouldn't do like, a total DVT scan from all the way from the iliac down to the perineals. We would do just a quick 3-point scan, would go, common femoral, mid femoral, popliteal, and a little bit below the popliteal, just to make sure that everything was flowing. And of course, we're not expecting the doctors here to do that, but this is just talking from experience. The pregnancy does increase the risk for DVT. So you may get that pregnant woman that has not gone to an obstetric doctor and she's given birth with a midwife, and it's been a totally normal pregnancy, and then she's showing up with pain in her leg. That's going to be something that we saw that a lot. So I suspect that's going to be something you see also.
Yeah. So thank you for that addition, Joseph. And of course, we talked about recent surgery. We talked about trauma to the upper limb, like fractures or chest or the neck, because all that is the cause. Remember, in the anatomy, we talked about, the upper limb cause. It is involving all that. Then of course, prolonged immobility, like when somebody has been bedridden or they have been in ICU for long. Of course, because of non-movement, then there is risk for DVT.
What about, Nelly? What about two things? What about, the patient, and one of my best friends is a vascular surgeon, so I was always in her department watching her sonographers go through some things, and a lot of times what she saw are these, middle-aged, maybe upper middle-aged businessmen and businesswomen that travel for a living. They're on a plane every day. And sometimes they're on a plane for, 10, 11, 12 hours traveling to Asia, do business, and then they're sitting on that plane traveling back. We saw a lot of those with deep vein thrombosis also. So, and I think that maybe goes towards the prolonged immobility, but not so much in the ICU or bedridden, but these people are chronic travelers. We saw that. And then what about like things like I don't know if you see this in your practice, Nelly, because I don't do DVTs. I only did it when I was, in training. But what about patients that have like factor five and those kind of blood diseases that or maybe those are covered under thrombophilia.
Yes.
Okay.
Yeah, those who are prone to DVTs. And when you talk about the people who travel a lot, that is something that I have first-hand experience because
Mm,
yeah, early this year I actually lost my partner to a DVT because he used to
wow.
travel a lot. He had a chronic DVT in the gastrocnemius, sometimes would
Oof,
default his medication, and he actually passed on because of P. It traveled all the way, and yeah, he got a
into the
pulmonary
lungs.
embolism. Yeah, and it was
Uh,
very sudden. So yeah, prolonged mobility is not only, in fact, I have to edit this, it is not only ICU, bedridden people, but also people who travel a lot. Because
yes.
like for him a year earlier, when I was picking him from the airport, I could see he had a slight limp, and I was like, "What is wrong with your leg?" He told me I have pain in my calf, and I didn't take him home. I took him to the hospital, and when we
Mm,
got there, I put a probe, and I could see there is DVT in the gastrocnemius, and he never
mm,
went home. He ended up in ICU for 2 weeks.
mm, mm. No,
Yeah, very
that
sudden.
is something that we should not take for granted. I can tell you my wife went to the UK. And the UK from South Africa is like 10 hours. And she went to visit her mom because her mom was critically ill and then came back. And then when she came back, same thing like you, I noticed that she was like rubbing her calf and just she's not one that feels pain a lot. And I said, "What's
Mhm.
wrong?" And she's like, "It just feels uncomfortable." And so you know me, Nelly, I have an ultrasound, portable ultrasound unit in my house. So I said, lay down on the bed and turn over on your side. And it was actually right behind her calf that she was rubbing, like in her popliteal area. Luckily, I didn't see anything. I mean, I did compressions and I did Doppler augmentation. I didn't see anything, but you don't take chances with those things because I've had also a friend like your partner. He's an avid bicycler. He does bicycling in the United States, and he started complaining, and he actually did pass away of a PE. So it's something that we do not take for granted. So why am I saying this to you, docs? Is not to scare you. Is when that patient comes in and if you don't see that vein and that vein can't compress, send them to radiology immediately. Because if you play
Mhm.
around with that thing and they sneeze the wrong way, that thing can travel
Mhm.
straight into the lungs. And once it gets to the lungs, I mean, you can do a
Mhm.
CAT scan to figure it out. Not you, but when they send them to radiology, we can do a CAT scan to figure it out. But by the point it gets to the lungs and they're short of breath, it's
Mhm.
almost too late at that point,
Yeah. Yeah.
so please, 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 if you can't handle it, send it to radiology. But I
Mhm.
think that the point of care vascular, one of the things we're teaching our Nigerian doctors is point of care vascular. Point of care vascular just says when the patient comes in with a pain at the point where they're pointing that this hurts, and you'll be able to
Mhm.
tell where it hurts because when you touch it, it will be painful. That's
Mhm.
where you scan, and that's where you find that vein, wherever, if it's
Mhm.
mid, distal,
Mhm.
popliteal, maybe, proximal perineals, but whatever it is that you where they're pointing, try to compress it. If it does not compress, send that patient to get a second opinion from a sonographer.
Yeah. So thank you for that. And of course, we talked about the patient history. If that patient comes with history of, recent travel, and they are telling you I have this specific pain, one of the things that should actually ring in your mind is could they have developed, some DVT, not only
Yes.
in the upper limb but also in the lower limb, anywhere.
Yes,
Yeah.
yes. One of the best advice you can give your patients that travel a lot, tell them just to go to Clicks, and Nelly, Clicks is our pharmacy here. Tell them
Mm-hmm.
to go to Clicks and pick up a really inexpensive pair of compression stockings when they
Mm-hmm.
travel. Because
Yeah.
now for me, I'm, turning 62 this year. So when I travel, I take it very seriously. I make sure I'm very hydrated. Okay, even though it's a pain in the neck getting up and using that airplane bathroom, but make sure I'm hydrated. I make sure that if it's anything over, let's say, 5 hours, I'm wearing compression stocks.
Yeah. So yeah, so the investigations that we would do, some of the checklist for the upper limb Doppler. Remember, we said we don't have a designed, score like the type of the well score for the lower limb. So one of the things that you could do is the D-dimers, which is useful to exclude DVT in low suspicion cases. Then compression Doppler, as we've said, is a first line, and it is non-invasive and highly sensitive. And of course, the other line that now would confirm if ultrasound is equivocal, you can actually send for a CT or an MRI venogram, depending on exactly what you're suspecting. Yeah. Yeah, because some of the things like the clavicle will limit, the assessment of the subclavian vein, and maybe that is where the problem is. So then some of the red flags, what are the things that would really tell you that, oh, this could be DVT? We have severe swelling, and in most cases, they would also be color change, and that would be like a vascular emergency. We also have associated dyspnea or chest pain. So consider that this could be pulmonary embolism from the upper limb Doppler, depending on remember, upper limb is closer to for PE. From the leg, it would have traveled probably over time. But for the upper limb, it is very close. Yeah. So in summary, we've said that there is no validated well score for upper limb, and you can use symptoms plus risk factors like what we talked about, the cancers and all that. Check the D-dimers and use the ultrasound approach. So in patients with catheters, cancer, or effort-related swelling, keep a high index of suspicion. So we've talked, well, the proposed, which has not been validated, but it is just a proposed upper limb clinical score, is that you use the signs and symptoms. We've talked about arm swelling, which is unilateral. It would equate to 1. We have arm pain and heaviness, plus maybe that would be +1. The other thing would be dilated superficial veins, or there is collateral. That would also be another +1. Tenderness along the venous tract, that is the axillary, the subclavian, the brachial, you put +1. There is limb discoloration or redness. It is also another +1. We have central venous catheters, line pacemakers, defibrillators, and all that. That would be a +2. Then recent surgery, trauma, or limb immobilization is a +1. We have strenuous repetitive arm activity is a +1. Active malignancy or treatment within the last 6 months is a +1. Known thrombophilia or family history of venous thrombosis or thromboembolism is +1 again. Hormonal risk, that is in pregnancy, is another +1. Alternative diagnosis or another diagnosis equally likely, like cellulitis, lymphedema, trauma, that is maybe what you're thinking that no, it may not be a DVT, but it could be this, then put -2. Then, of course, the scoring, the interpretation is that if it is 0, there is low probability, consider D-dimer. If negative, upper limb DVT is unlikely. If you get a score of 1:3, then we have moderate probability, that is order a Doppler ultrasound, a comprehensive Doppler ultrasound. If we have anything that is greater or equals to 4, that is high probability, treat that as suspected upper limb DVT and get an urgent Doppler or a CT or an MRI venogram, depending on what is your suspicion. But of course, the first thing would be radiology to go and check for DVT using that ultrasound comprehensively. So this is just something that I found, which I probably needed to just share, is that pulmonary embolism, that is PE, it occurs in 10 to 15% of cases. And this is higher in catheter-related upper limb DVT. But in lower limb DVT, it occurs in 30 to 50% if it is untreated. So why I'm trying to say this is that it is a major cause of morbidity and mortality. That is, any DVTs is really high risk. Then post thrombotic syndrome, it is less common than in lower limb, that is 10 to 15%, but it causes chronic swelling, heaviness, and venous collaterals. Then, of course, functional limitation in upper limb DVT, more common, which is 20 to 50%. There will be chronic pain, edema, skin changes, venous ulcerations, and all that. Recurrent thrombosis is common if risk factors persist. Like, for example, if you have indwelling catheters, you have pacemakers, there is malignancy, recurrence it is common. Then loss of venous access, that is unique to upper limb DVT. Thrombosis of subclavian or axillary vein compromises future central line placement. Yeah, that is like those chemopods as well as dialysis and all that. So then we have functional limitations when you have arm heaviness, fatigue, limited range of motion, especially in effort thrombosis. In lower limb Doppler, there is leg pain, heaviness, impaired walking, and reduced mobility. Those are some of the things you should be watching out for. So complication of DVT in both upper limb and lower limb, it can cause to pulmonary embolism, which is a major short-term risk, recurrence, and also post-thrombotic syndrome. Then we have lower limb DVT has high rates of PE and post-thrombotic syndrome and risk of venous ulcers. Upper limb has unique issues like loss of venous access and arm functional limitation. Post-thrombotic syndrome is a chronic limb pain and swelling that will keep recurring and recurring. Then, of course, they could also be recurrent thrombosis. And therefore, when your patients maybe present with DVT, you should encourage them to be compliant with their anticoagulant medication. There are people who get tired, they get medication fatigue, and then somehow they leave their medication and the thrombus recurs again. Yeah. So you should be able to just, encourage them. So, of course, that is what we've talked about. Post-thrombotic syndrome, recurrent thrombosis are some of the complications. And of course, PE, which is life-threatening. And so I don't want us to do the case studies here. Okay, let me just say, let's do it quickly. For this case, for example, a 55-year-old male with unilateral calf swelling and pain, what would be your thinking as a doctor? This patient has just come to your department, 55-year-old male with unilateral calf swelling and pain. What could be a likely finding?
What do you guys think? I can think of two differential diagnoses right off the top of my head that I would think, and maybe Nelly may say that I was wrong. So if not knowing anything else about their history, Nelly, I would say it's either I would say it's either it's unilateral. So it's either a DVT someplace in the calf, like along one of the perineals, maybe anterior tibial or something like that, or it could be something completely unrelated to a DVT. I mean, it could be you know, he could be an athlete and, had gotten, because I did that and I had an abscess in my calf. So that may be, or hematoma or something like that. So I think the DVT, we can't rule it out without scanning. But at the same time, those are my differential diagnosis. I don't know. Can I have some comment from, let's say, Dr. Colleen or Dr. Jasub? What do you guys think?
So I kind of agree with your thinking about the DVT. Then I guess on ultrasound you'd expect to see a non-compressible vein, and then maybe an echogenic thrombus in the vein.
When you
and
put color.
you'd have reduced flow on the color or absence on the color Doppler.
Mm.
So
Yeah.
that is good. And of course, this is a patient that qualifies for vascular POCUS.
Mm-hmm.
With that history, just having come to your department and they have that history, this is a patient that qualifies for you to put your probe there and check is the vein compressible. And especially in the cuff, we would find the gastrocnemius.
Mm. Mm.
Yeah. So then we have another patient here, a pregnant mother with tenderness along the femoral vein, and there is no history of trauma.
Mm.
So my question is, is this patient likely to have a DVT or not? It's just a yes or no.
So, guys, we talked about the pregnancy. What did we decide? Okay, so Dr. Jasub said yes.
What are the reasons?
Pregnancy is a hypercoagulable state, so it's an increased risk of DVT and clotting and that kind of thing.
Yeah, so there are several factors. Of course, we talked about the hormonal factors. We also talked about even immobility. Most of them, maybe they sit a lot, they are tired, and then the weight as well of the pregnancy, it compresses on the common femoral veins and even the external iliacs. So it could still be pregnancy could arise. I mean, DVT could arise from any of those factors. Then what if I have a well score of 3? What does it mean?
It's a higher chance of having a DVT is three or more.
Yes. So 3 or more means that there is high chance of DVT. So I want to do a quick recap, as I said, of the anatomy, because that is how you'll be able to scan. The only time you can understand where to find your vein is when you know your anatomy. This is just like a recap. And of course, I don't want to start from the brachiocephalic because of course it would come, divide into other branches, but let's start from the internal jugular here. So we have the internal jugular vein there, and immediately after, as we are going down, is above the clavicle, we have the subclavian. Then we have the axillary, which is under the armpit. That is where you will place your probe when you're looking for the axillary vein. Then we have the basilic, which we said basilic is superficial. You see the one that is transversing, continuing, the dark one that is in the middle, that one is the brachial. But the ones that are superficial, which is branching off, if it is branching off medially along this medial portion of the hand, then that would be the basilic. The ones that are running here, that is the lateral aspect of the arm here. All those are cephalic from up to down. This the same from up to down, all of them are basilic. You'll only be describing them, saying, is it proximal, mid-arm, or distal as you go down. And you would say above elbow or above cubital fossa. Then when you're describing them, when you're coming down, you can actually say it is proximal, mid, or distal arm. But they're all basilic. Yeah. Then we go to the lower extremities. We have the common femoral, which we said we usually have the common iliac, but where we start scanning, where you'll put your probe and you can easily see, is at the groin area, where you will actually be seeing the common femoral vein, and that is also what is known as the deep femoral vein. It is another name. Then we have the superficial femoral, which we said it is not actually superficial. It just has a name, superficial femoral vein, but it is actually a deep vein. Then we have, after that, we have the popliteal. And as you can see, just after the popliteal, you have the gastrocnemius, which is usually at the calf region. We have the gastrocnemius. Then the one that runs anteriorly on the lower limb is the anterior tibial. The one that runs behind is the posterior tibial. And then, of course, as you continue down, it goes into the digits, which we do not want to go much into that. So before I conclude, I just want to share something else here, which is like a quick recap of what we have learned. And I'm not sure if you're able to see my screen.
Not yet. Not yet.
Oh, how do you share this? Oh, okay, I don't think this is it is in Word document, so I don't know if it is shareable. I'm not very sure. But it's okay. Maybe I could just read through so that it's just a recap. So we've said that vascular POCUS is, of course, a bedside technique, and it is used to evaluate venous, assess hemodynamic, and guide in vascular access. We are checking for deep venous thrombosis, and we also want to evaluate vessel patency, compressibility, and flow. And we want to identify pathologies such as DVT, aneurysm. We talked about aneurysm last time when we were doing the abdominal, and we talked about identifying your aorta at the just at the subxiphoid area, and you measure that AP diameter before the celiac trunk. You measure after the SMA, which is after the celiac trunk itself, and you follow it all the way down and measure just before it bifurcates into the right common iliac and the left common iliac. Why we are measuring that is the measurement should be tapering, it should be reducing. Remember the aorta tapers, it becomes smaller as it goes down. So anytime you find a bigger measurement in between that is larger than the first one that you got before the celiac trunk, that could actually point to an aneurysm. It may not be pulsatile like the ones that sometimes patients present in the department with, you put your probe and it is throwing it off because of the pressure. Sometimes it is just an early aneurysm, and therefore that measurement is very important. And we talked about the transducer. We've talked that we are using a linear probe, which is 7 to 18 megahertz, that is for superficial vessels, and curvilinear for deeper structures, but you adjust your frequency. And when you're doing your machine setting, you should be in the right preset, which has to be vascular or small parts. And you can also utilize Doppler. Then, of course, for the patient preparation and positioning, you need to explain the procedure, and you also need to obtain consent from the patient. And of course, the patient will be lying supine if you're doing the lower limb with the hip externally rotated a bit. And also, if you're doing the upper limb, you can ask the patient to sit facing you so that you're able to assess your subclavian very well. When you're doing the axillary, you can ask the patient to lie down. And remember, of course, when the patient is seated, it gives you that, gravity, how the blood should actually be flowing. It will be easy for you to locate the vessels. And then, of course, we've talked about I want to just give you a step-by-step, way of performing that DVT assessment in the lower limb. We say that you start at the inguinal crease, identify the common femoral vein, and do compressions. Apply gentle probe pressure every 1 to 2 centimeters, and vein should completely collapse. Follow the common femoral to the femoral, superficial femoral, and compress at proximal, mid, and distal. Remember, we were talking about the 3 points. And we also do the popliteal region. And of course, what is optional is the calf veins, but if there is swelling, make sure that you actually check to be able to see if there is any thrombus within the gastrocnemius or even within the peroneal veins, though you may not be able to see that and identify which is which, but you'll see, if you put color, you'll see there are a number of vessels there. Then, of course, we've said use color Doppler to confirm venous filling and phasic blood flow. And then, of course, for the upper limb, our main idea here is to rule out thrombosis before cannulation or dialysis. And the step-by-step is that place your linear probe on the internal jugular, that is along the neck. check for compression. Then, of course, the next is that you do your supraclavicular fossa, so that you're checking the subclavian, that is where it will be. You identify the subclavian, check the axillary under the armpit, check also the brachial veins, and then assess compressibility and also use color Doppler as we said, and evaluate for thrombus, wall thickening, or extraluminal compression. So I think with that, unless there is any question, we have we are done with the vascular. And if there is anyone who needs any clarification, I can be able to give. And maybe just to add is that for the aorta, it should always be less than 3 centimeters, and you measure outer to outer wall. For the IVC, you want to check its collapsibility during breathing, and at the widest diameter, it should also be within 1.5 to 2.1 centimeters, especially when you want to evaluate collapse for fluid status, like patients who are dehydrated and all that, and you just want to check the diameter of the IVC, it has to be around 1.5 to 2.1.
Okay.
And then, of course, you need to document whatever you've seen. Some of the limitations is obesity, subcutaneous edema. It will give you artifacts, when there is fluid. It will actually give you, it will cast shadows. Of course, when you're checking the IVC and the aorta, there could be gas obstruction. And we said to eliminate those artifacts, you angulate your probe, or you compress, or you ask the patient to blow up their tummy. There are different maneuvers. And then, of course, you need to keep practicing, as we said, so that you can improve your skills and it will make your life easier. So thank you so much.
Thank you, Nelly. Thank you so much. I always found that when I was rotating through and hit radiology, DVTs were difficult for me. Actually, I learned the lower extremities pretty quickly. The upper extremities completely to this day confuse me, because there's just too many veins and things that twist around the arm. So it's Nelly saying the more you practice this, and our sonographers are really good. They actually drew on themselves for me. They took a surgical marker and actually drew on their arms to show me where the veins and things were so they would help me actually find it. So I'm very thankful to them to this day. Some of them are retired now, but thankful to them for this day because they did that. But if you guys have any questions before we close off, any questions, guys? Any comments? How did you guys think this was? Was this good? Was this information you did not know before? What do you guys think? You guys are all quiet. It must be asleep. Okay, very useful. Thank you, Dr. Nair. I know you're putting your children to sleep, so thank you very much for that. And as always, please text Donica or Dr. Martinison and let them know how these sessions went so we can improve on them for the doctors that are coming behind you. So I won't keep anybody tonight. Good night, guys. Nelly, thank you so much. You and I get some rest tonight. You and I have several meetings tomorrow. So we will see you tomorrow, and the rest of you guys, we will see you later. Have a great, great evening. Good night.